So anyhow, it's part of our party platform. And the latest iteration you might have heard of was SB 562, right? Anyone know why it was called that? It was the lead author was Ricardo Lara from Long Beach. You know what their area code is in Long Beach? 562, right? And it was doing pretty well. It got through the Senate, and then Anthony Rendon, a colleague, you know, the Speaker of the Assembly, our Democratic 2/3 majority Assembly, held it up. He shelved the bill. He said it wasn't adequate, you know, it was incomplete, but, you know, he could have completed it, right? So what was holding him up? Money. The people versus the money, right? And so we haven't done our job. I don't blame him. I blame us because we haven't raised enough awareness and enough demand for this at this point. There's efforts at the state level and also at the national level, of course. And the latest iteration in Congress is H.R. 1384 that's being put forward by Pramila Jayapal from Washington State. Previously it was John Conyers from Michigan who put it forward. In like the last six or seven sessions of Congress, Conyers kept putting forward H.R. 676. And we actually had more co-sponsors of that legislation than we do now for kind of very weird reasons. But again, people versus the money. So, you know, I always say it's like they say at first they ignore you, then they laugh at you, and then they fight you, then you win. You win, right? So right now they're fighting us, which means we're very close to winning. Okay? Because they used to not take us seriously, and they thought, okay, I can sign on to this legislation, you know. I can tell you Adam Schiff has signed on to it. Yay! Yeah. Brad Sherman has not. Don't boo, vote. So who else? Gil Cisneros down in my neck of the woods in Orange County has not signed on to it. Katie Porter has. Yay, Katie Porter. Judy Chu has. Yay, Judy Chu. Maxine Waters. Most of the California delegation has signed on to it, but we have holdouts for not really good reasons. A lot like what, you know, Speaker Rendon said. Oh, we have to figure out how we're going to pay for it. Fine, you do that. Go ahead. Throw it in the bill. It's called the amendment process. You could do that. I don't know if any of us, I know Carol probably watched the House hearing that we had. We were promised 2 hearings by Speaker Pelosi. One was the House Rules Committee, one was the House Budget Committee. We had the Rules Committee. The chair is a very good friend of Progressive Democrats America named Jim McGovern, and he was happy to host the hearings on Medicare for All. We had a rather famous fellow who's unfortunately now wheelchair bound by the name of Adi Barkan. And he gave a very striking testimony there, and how he needed Medicare for All yesterday when he came down with Lou Gehrig's disease, ALS. So, you know, that's what's pushing this forward. The next committee would be Budget Committee is supposed to hear this bill 1384 on Wednesday, this Wednesday. So for those of you who are C-SPAN junkies, maybe like me, actually you don't have to watch it on C-SPAN. All the House committees have their own live web stream. So you can go to house.gov and look up committees. I think this would be budget.house.gov and watch the live stream on Wednesday as it moves to the next committee. But the good news coming out of Rules Committee was we're not going to get hurt in Ways and Means. And that's huge. Ways and Means is a real committee of jurisdiction. So we're very excited that that bill's moving forward. On the Senate side, of course, who's in charge of the Senate? Oh, I heard that. That's not really his name. It's Mitch McConnell. Yeah. So you know, so Bernie Sanders' bill 1129, although he's got 16 co-sponsors, including Kamala Harris, but not including Dianne Feinstein. but he's got 16 co-sponsors. All of the senators who are running for president have all co-sponsored Bernie Sanders' bill, but they're not proceeding with any hearings. Wonder why. So we don't expect this to get passed out of Congress and to the president's desk. And even if it did, you know, look at the president we have. So we're looking at moving this forward because of the information. Okay? Because the public needs to hear about it. This is the first time in history that a single-payer solution to our healthcare crisis has been proposed and heard now in Congress, which is fantastic. I mean, that's terrific. Yeah.
Could you just answer a question? What does it actually single payer mean?
Yeah, okay. So let's do that by, oh, sorry, nothing really. Let's do that by going to the next section on this handout, which says Essentials of Medicare for All. Okay? So we mentioned eliminating waste, fraud, and abuse. And by far the largest category in there, although the fraud and abuse stuff can really get us angry, but is the waste. So right now we have inherently so much waste because we have all these different payers, meaning insurance companies, private insurance companies. So you have Aetna and Cigna and Kaiser, and all these groups are insurance companies. You know, Kaiser is also a provider group. I actually worked for, full disclosure, I worked for Kaiser for 30 plus years. So I actually understand that system, and they would do terrific under a single payer model, frankly, despite what you hear from their industry spokespersons, who are way at the top and they're protecting their own jobs, you know, primarily, in my opinion. But there's tremendous waste. It's a third-party payer. And that means that all these other countries have eliminated those third parties. You know, Dr. King would say it's immoral to profit off of a condition of human need. People are taking money out of the pot, you know, and putting it in their own pockets and doing it in a very secretive, kind of nefarious way. So we look at these CEOs, what they're being paid, CEO pay, advertising, but especially in claims processing. All that stuff where you send in an insurance claim and they deny it. You know, a doctor sends in you know, a claim on an office visit or a procedure that they did. And the insurance company denies it. And so you got to get somebody on the phone with them and say, why'd you deny it? Everything's right. We did this, we've done this 100 times with you guys. So, oh no, there's a new policy, you know, blah, blah, blah. You didn't cross your T's, dot your I's the way you're supposed to. That's incredibly inefficient. And when the system is simplified to a single payer, meaning us, meaning we the people, not some corporate boardroom, you eliminate all that waste. I mean, a good chunk of it. So if a third of every healthcare dollar right now is going to, you know, is gone, it evaporates out there in waste, fraud, and abuse. So the other part is the fraud part and abuse, you know, in my opinion. I already mentioned a lot of negotiation in private insurance goes on behind closed doors. You and I have no idea how or why the bill is what it is when you leave the hospital. We don't know. That negotiation's gone on behind closed doors, unless it's Medicare. Medicare knows. Medicare has a board that evaluates this and decides, are these legitimate, you know, claims, expenses, and are we going to reimburse, you know, for what that provider's asking us. Now, doctors generally don't refuse Medicare. They do refuse Medicaid, which is Medi-Cal in California, right? That's why, you know, a lot of doctors won't take Medi-Cal. It has a lower standard for reimbursement and for the quality of care that's delivered. But Medicare doesn't. That's generally very adequate, and it's very above board, transparent. Generally, you know exactly what Medicare is going to pay for and what they're not going to pay for. So that gets into the fraud part. The abuse part I like to save for pharmaceuticals and pharmaceutical companies. So that's usually a part of, you know, the single payer model is also the ability to negotiate with drug companies. Okay, so like Barack Obama had proposed that with the Affordable Care Act, and Big Pharma made a deal, cut a deal, so that they could be cut out altogether. Like the Affordable Care Act just delivered, I don't know what it was, $40 billion or something to Big Pharma, so that they wouldn't be part of that, and we would back off on trying to negotiate prices. The VA system, for example, is a single payer system. They have the ability to negotiate drug prices. You know, Kaiser Permanente is such a big company. They negotiate with pharmaceutical companies and bring down their medication costs remarkably. That's part of the reason they can exist like that, and part of the reason they're you know, competitive compared to other companies who do that too. So maybe that's why they don't want it, because they don't want you and I, you know, as we the people, the government, to be able to negotiate those drug prices. But it's even more basic than that. So I like to do, it's like Econ 101. And the model I like is the EpiPen. Everyone heard of the EpiPen? That's right in my area of expertise, emergency, right? Emergency treatment for allergies. So, you know, so this is a drug that is incredibly important to those people who have severe allergies. It's vital. And the drug companies now are so fraudulent, so abusive, so exploitative, so extortionist at this point. They're holding you and me and anyone we know and love with allergies hostage over what they can charge for that drug. What do you think it costs to make an EpiPen?
A couple of pennies.
Pennies. Well, I give them about $1.25, but I'll let them sell it for $5. What do you think? Anyone know what it costs to buy an EpiPen?
$600.
It's $300 a piece, or $350. They make you buy two for $700. Yeah, you have to buy two. There's so much wrong with that. Okay, what's the drug epinephrine? What's the common name for it? Adrenaline. Where do they? That's been around forever. It's a generic product, it's naturally occurring generic product, and they've known how to extract it out of beef and pork and, you know, animals for forever. As long as we've eaten animals, they know how to get adrenaline out of them. No, not quite, but, you know, at least 100 years it's been around. So what do you think that dose of epinephrine should cost? Pennies.
Pennies.
I give them a dime.
Okay.
Let's give them 25 cents, okay? So now we're gonna say, okay, what about the injector? That fancy spring-loaded thing comes in this bright yellow thing with exotic packaging around it and all that stuff, right? So this is like when I took Econ 101, you know, at UC Santa Cruz, I had a professor who said, they're just, you know, they're milking people for money by, you know, giving you these products that have nothing to do with the stated function. I mean, for example, the spring-loaded function of an EpiPen, you don't need a spring. You can push the plunger down yourself, I think. You know, remember those little things they gave out in the battlefields in World War II, and morphine? Little tiny syringes, you know, and yeah, you could put it right through your clothes. Ooh, you know, it's very dramatic, right? You do the same thing with Epi. It could be in a little syringe where you push the plunger. It doesn't have to be some fancy spring-loaded, bright yellow, you know, with warnings up and down it. Like, you know, there's also planned obsolescence built in, by the way, because the epinephrine, the adrenaline, has a very short shelf life. Pills, you know, expiration dates on pills can be years. Usually liquids are just months. So you got to replace those all the time. You got to have one in your car, one in your boat, one in, you know, to take on a kid, send your kid to school with one, you know, whatever it is. They know this, and they're getting that money out of us every bit as much as exotic antibiotics. You know, people with HIV come down with exotic infections. They price these things based on what it's worth to you, not what it costs them to make and distribute them. And that's fraud and abuse. They are holding us all hostage at this point. So that's what we're talking about, a single payer system. It eliminates all the redundancy and waste in the system, but it allows us to have that kind of leverage over fraud and abuse as well. And we'll take more questions here in a minute. So that was the predatory pricing of pharmaceuticals. Let me make sure I cover everything here. The good side of a single payer system is that you have complete choice of providers. And if you want to see Dr. Ed, you know, you can, whatever your group is. You want to go to Kaiser, you can. You want to go to Cedars, you want to go to, you know, anywhere. The Mayo Clinic, you can. Now, Dr. Ed may have a very long waiting list to get to see him, you know, in Boyle Heights, but, you know, more than the Mayo Clinic, but you can. You can get on their waiting list. And that's what Canadians do. They just get on a waiting list, you know, and guess what? They still live longer than we do. You know, like people, remember when they used to say that drugs that you buy in Canada or Mexico are inferior to ours. Why do they live longer than we do? It's not true, okay? We call BS to that. Like I mentioned, the reimbursement to doctors and the hospitals is standardized. They know exactly what they're getting, you know, so there's none of this behind closed door stuff. And we need to ensure and enshrine the qualities, the standards are at a Medicare level, not Medicaid level. Which really kind of brings us to the next section, what Medicare for All is not. And I always say it has to meet those two criteria. It has to be Medicare, which is expanded and improved, and it has to be for all. Okay? So if it's Medicaid for all, that's not Medicare, right? We know why. It's an inferior quality of standard and reimbursement. Okay? Not Medicaid, okay? Medicare. And it's not Medicare for some. I mean, if you're going to buy into it, if you're going to have a copay or a deductible, or which includes, you know, your prescription drugs, and I would say non-prescription drugs too. You know, we ought to cover Tylenol. You know, for that matter, if you need, you know, acetaminophen because you have a fever or, you know, headache or pain that it takes care of, we can cover that. We can do that. We're the richest country. California is the richest state in the richest country in the world. We're the 5th largest economy. If there is a country or a state that can cover all those things, it's California. We ought to be doing that yesterday, you know, but I'll settle for today. So that's you know, you might have seen the hashtag Medicare for All. Some people have created a hashtag Medicare for some. Doesn't sound so good, does it? No. So public option works the same way. You know, if you opt to be in the public plan, well, what about the people who are getting private? You know, they don't go well together. I mean, private insurance companies cherry pick. They take out the people who are sick, and that leaves people who are relatively healthy. And also, they're driving costs in the whole system. So it doesn't work that way for economic reasons. That's why we ought to all have the same, and that, again, is the for all part of this. That's why public option is not Medicare for all. And then, let's see, we already covered Medicaid as a lesser standard. The working parts of the system actually exist already. I mean, you can look at the VA. They have very good numbers. The VA, once you get in the system, really the problem with the VA system is access. Right, it's access. Once you qualify, the people who have VA care are actually very satisfied with it. They have access, you know, once you're in the system, you can see your doctor whenever you want. You get good, you know, follow-up care, get lots of social support in the system. Okay, Medicare is close to that, you know, and we have the apparatus already. I mean, in 1965, when it was first signed into law, it took like a year to start up. So how, you know, now with so much computerized, you know, how long do you think it should take? I think it could be done overnight, you know, because it's on computer. The Center for Medicare and Medicaid Services, they have boards that make these decisions already. What's legitimate expense, what isn't. It's scientific, evidence-based best practices. That's what I always say about Kaiser. What a good thing about Kaiser is that it's a multidisciplinary, meaning all the specialists sit down together and figure out their drug formularies. It's not some drug company saying to an insurance company, this is what you're going to have on your formulary. It's the doctors and nurses and, you know, therapists sitting down and deciding what's on their drug formulary. And that's what they call a multidisciplinary group model practice, where you can sit down and decide those things. Now that's kind of an intermediate between what we'd call a solo practitioner and a big institutional group. So like say a teaching hospital, LA County or something, or UCLA. I mean, that's very kind of impersonal medicine. They call it doctor by committee, as opposed to doctor by committed, like the Marcus Welby solo practitioner model. I'm looking at Ed because I don't know what your practice is in that spectrum. But Kaiser's like in between. It's in the middle. You know, it has elements of both. You can have the same Kaiser doctor for 10, 15, 20 years. At LA County or UCLA, it's probably going to be 2 or 3 at the most before they have to switch and rotate. So that's kind of the spectrum of care, and everybody should feel comfortable, and be able to decide that. Do you want to go to a big teaching hospital? Do you want to go to a solo person that you really trust? Or do you want to go to something in between? We need to have that kind of choice, that freedom of choice. Actually, it's a freer and more fair market system to do it that way. And again, that's what every other country has decided. So that's what a Medicare board does. It makes those decisions on what's legitimate expenses and reimbursements, a trust that will take in the money and make sure that nobody is pulling out of it. Like, remember Al Gore's lockbox? So we need somebody who manages the trust fund and make sure that Mitch McConnell can't get his greedy hands at it, or the Koch brothers. And then what I call Medicare facilitators, care facilitators. So all these people who currently have jobs with insurance companies, red line, no, you're not going to get care, no, we can't do that. There was a famous case, a young lady, I think from the Valley or maybe the foothills area here, by the name of Natalie Sarkeesian, some years ago. 17-year-old came down with liver failure. Who knows how, right? Maybe just primary. Can't blame it on Tylenol or alcohol or anything, or hepatitis at that point. She just came down with liver failure, and she was denied by Cigna. She was denied a liver transplant. I don't know what it was, 6 or 7 times. They kept submitting, from different doctors. They all said the same thing. She needs a liver transplant. Cigna kept saying, no, it's too experimental, too costly. Actually, I don't think they ever used the word costly. They just said, no, it's not accepted practice or standard of care or some. Well, who's saying that for Cigna? Who says that? For the government, we have some idea who's saying it. I mean, we elect those, mofos in Washington. So, you have some input on that when it's us making those decisions. And again, Medicare does that, the VA does that, and they have better outcomes than the rest of the population. So that's what we need. And then those people who currently work in, kind of redlining things for insurance companies, they can be reemployed as people who help you get the things that you need. Like if you're a diabetic, do you have enough test strips for your glucometer? Do you need a pulse oximeter at home? Are you an amputee? Do you have amputee needs or that kind of thing? So it's not that hard to retool the industry. And every bill that's ever been proposed for a single payer system, Medicare for All like system, has included that in it, including these 2 bills now in Congress, 1384 and 1129. HR 1384, S 1129 are the numbers. So that's kind of the basics of it. I also listed here the kind of premier organizational groups pushing this forward. So for your reference, down at the bottom of the page, my group, Progressive Democrats of America, on the issue side, we call ourselves People Demanding Action. So feel free to look up the information there. We hold a monthly conference call. All are welcome to join us. I think we're moving to Zoom meetings. Anyone done Zoom meetings? Kind of fun. It's video conferencing, so you all feel like you're in the same room, which is way more personal than a phone call. Healthcare Now, Physicians for National Health Program, PNHP, has been around about 30 years, came out of Harvard Medical School, not a slouch academic institution, no. We're not talking about, what's that, Liberty University or something? Or Donald Trump University? Harvard Medical School, School of Public Health, saw the writing on the wall about 30 years ago. And they said, we're going off a cliff in healthcare. We need a national health program, a national health plan. Like, you remember Ted Kennedy's National Health Insurance? So that was like 1970s. That's when PNHP started up. And they're MD, PhDs largely, so they're academics who study, compile data, give it to the World Health Organization, and all of that. Like all the data that I mentioned at the top of this talk, or page here, most of that's from PNHP. So if you want to look up the science, the data, wonderful charts and graphs and stuff, for those of us, kind of nerdy people who like charts and graphs, that's at PNHP. Healthcare for All California is a state-based movement. working on both state and federal single payer, and then National Nurses United. Of course, the nurses have been probably the strongest champions. We now have with us NUHW, National Union of Health Care Workers, which includes also clerical people, therapists, other people, more so than just the nurses. So all these groups are working on this right now, at a feverish pace. So check out those organizations. Join them all, because who doesn't need more emails, right? No, so you're in the loop. You know what's going on that way, and you can just kind of rifle through them like I do in my emails. But every once in a while, someone will catch your eye. So that's all I had by way of kind of information for you. I just at this point I would welcome either questions or comments that you have about this altogether. Thank you.